good for this?
I already kissed the button.
Yeah.
Number 3 and
One.
number 1.
Yeah.
Three down. Three down.
Number 3 for
Three off. Three down. Yep.
3 down. For the 3 from the speaker.
Hmm?
Number 3. Number 1 for
Number three. Like normal. Number three for the speaker. Number one for me. Hello. Hello, everybody. Welcome back to our final day of EMS Conferences Bali. All right, well, we need to practice that. Thank you, everybody, for turning up today. I do hope that you've had a really, really wonderful experience this week. But in tradition, what we need to do to start this session off is we need to complete our Instagram competition. So I would like to based on that response, I think we need to warm up a little bit here. So we need to warm up our clapping hands and our loud wooing voices. On the count of 3, please, what I would like is a very, very loud clap and very, very loud woos so that we can get warmed up for this next segment. Are you ready? 3, 2, 1. That is much better. So, without further ado, here is today's entrance into our door prize for a very, very exclusive EMS Conferences door prizes. That's cute. On the count of 3, or I'll count down from 3. 3, 2, 1. Our next entrant. I love my job, EMS Conferences. I like that. 3, 2, 1. Good, good. Our next entrant. That's lovely. 3, 2, 1. Was that you, Rob? Our next entrant. Oh, this is cool. 3, 2, 1. Very good. Oh, lovely. At Water Bomb Bali, of course. 3, 2, 1. Very, very good. All right. And then our next entrant. A cooking class. 3, 2, 1. And another food-related post. Sky again. 3, 2, 1. And now our final entrant for today's door prize. Obviously at Waterbomb Park. Keely. 3, 2, 1. I think that today's is very clear in that Keely, congratulations, you have won a door prize. Come and see us afterwards. Okay, so we'll crack straight into today's session because obviously we want to be out of here at 4:30 sharp so that we can catch those last dunks of the pool before we head to the closing party tonight. So I would like to welcome to the stage Lorraine Curammeng, Quality Coordinator at a Perth-based healthcare not-for-profit, to discuss stopping the spread. Make Lorraine feel very welcome.
Thank you. Hi, good afternoon, everyone. So I think most of you here have been here for already how many days? Whereas me, I just arrived about 12 a.m. Today. Little jet lag, so that's why I'm trying to avoid Q&A. So I know this topic is something that all of you already know, so just think of me as your human e-learning person, and that like what we always have every year, every 6 months for your fire training or everything. So this is just a reminder, and I know that we're all guilty of this one. So without further ado, again, my name is Lorraine Curammeng, and I'm a registered nurse with 17 years of experience, originally trained in the Philippines. Any Filipino here? All right. I think it's just me. But yes, I am trained as well in New Zealand. And then I moved to Sydney in 2012 and then moved to Perth in 2014. So I currently work as a quality coordinator in a not-for-profit aged care community services organization in Perth, Western Australia, supporting clinical governance and quality improvement across multiple facilities. And we have 5 facilities in Perth. But beyond my role, I'm also a mom of 2, an 8-year-old who Mark saw, and a very energetic 3-year-old who was here earlier. So trust me, I know a thing or two about infection control, both inside and outside the workplace. So is it just pressing this one? Okay, all right. So now I know what you're probably thinking. Oh, great, another infection control session. And honestly, you're not wrong. So it's another infection control session, but it's just a reminder for everyone. Okay, so next slide. Just go. Okay, so all right, let's talk about why IPC matters. And I know that what you're thinking, we already know this. Wash your hands, wear PPE, don't sneeze on people. And you're right, we do know it. But here's the reality. Even though we all know about 70% of healthcare associated infections are still preventable. And that means 7 out of 10 infections we could have been avoided in the right practices. And the impact is huge. These infections lead to longer hospital stays, increased costs, more complications, and yes, even loss of life. But here's the part we often don't think about, and it's not just what we do that matters. It's also what we don't do. So every time we forget hand hygiene moment or skip a cleaning and a shared piece of cleaning a shared piece of equipment, or assume someone else wiped that surface, those little inactions add up. Okay, so you already know this, but I just call it the chain of infection and knowing our enemy. And this is just a refresher that you already know. So, framing the enemy. So we have the infectious agent, the reservoir, the portal of exit, and the mode of transmission. So now if infection prevention is the battlefield, then this right here is the chain of infection. This is the enemy's playbook. And yes, I know we've all seen this diagram more times than you've had coffees on your night shift, but stay with me, because how we think about each link is often more important than memorizing them. The idea is simple. Infection doesn't just appear out of thin air. It follows a series of steps. It follows a chain. And here's the good news. If we break even just one link, the infection can't continue. And that's what makes understanding this so powerful, because prevention is basically sabotage. And our job is to interrupt the enemy's plan. Just trying to get onto, sorry. Trying to get on. Sorry, I'll just get through my laptop. Some more information. as well. Sorry about that. Just a little icebreaker. Just move as well. Okay. I'll just move through the infectious agent. So the first link is the infectious agent and the pathogen itself, with which initiates the infection process. And then next is the reservoir, the natural habitat where the pathogen thrives. Then the portal of exit, you all know the route by which the pathogen exits is reservoir. And lastly, the mode of transmission, the means through which the pathogen spreads to the new host. So, transmission pathways. Now that we've gone through the chain of infection, let's zoom into what I think is the most practical part of us, how infections actually get from point A to point B. And we call this as transmission pathways, which you already know, and they're basically the routes the pathogens used to hitchhike from one person's surface or environment to another. And spoiler alert, we're usually the Uber driver. So what's important to remember is that if we know how the bug moves, we know how to stop it. And when you start recognizing these pathways in real time, during your shift, during patient care, you'll find dozens of opportunities every day to break them. So that's the contact, the droplet, and airborne. So I just put it there, like how they move. And the animation, so contact. So direct or indirect transmission through touch with infected individuals and surfaces. And then we have the droplet. Spread occurs via respiratory droplets expelled during coughing or sneezing. And lastly, the airborne, infection risk from pathogens suspended in air over distances. Okay, let's be honest for a second. If I had $1 for every time we were told to wash our hands in our careers, I'd be retired on a beach somewhere by now. And we all know hand hygiene is the single most effective way to stop the infection. And it can reduce transmission by up to 40%, and yet compliance rates are still often below 50%. And that's less than a coin toss. If this were a treatment with a 40% reduction in mortality, we'll all be screaming to fund it. But because it's soap and water, it gets ignored. So why do we keep on getting this wrong? Most of the time, it's not because we don't care, and it's because of some 3 things. Okay, next slide. Just gotta hold on to this. I'll just go through my own notes here. All right. I'll just go and proceed through because there's some technical difficulties that we can't go through, but I'll just go through with a reflection. So, all right, let's switch gears for a bit. We've talked a lot about hand hygiene, environment, transmission chains, but now I want to make this personal for everyone. So I want you to take a moment and think about your usual workday. So picture yourself from the time you stepped into your shift to the time you leave. And then you ask yourself, where are the 3 points in my day where I might be accidentally helping a pathogen travel? It could be as simple as rushing from one patient to another and forgetting hand hygiene just this once, or reaching your phone or pen in between procedures. So touching a keyboard or a medication trolley without cleaning your hands. So just take in about 30 seconds and think, you don't need to share, but it's just a reflection for you. Just list them quietly in your mind or jot them down over your phone or notepad and just pause them, give them 30 to 45 seconds. And it's also very important because I'm fully aware that I think the next presenter here, which is all about, is it okay to disclose? Is all about sepsis. So yes, it works closely. So it's just taking time to reflect for yourself what you could avoid as well to avoid contamination. So that's it. Think about your daily routine, even at home and at work. So beyond your hands, surfaces, and equipment. So we've seen how easily the pathogens spread through contact, but here's the part that often gets forgotten. Our hands are only one part of the problem. The real battlefield is the environment around us. The bed rails, the blood pressure cuff, the medication trolley, the mobile phone you're scrolling on during our break. We focus so much on PPE and hand hygiene that we forget this. If the surfaces we're touching are contaminated, our clean hands don't stay clean for long. So one is pathogen survival. Pathogens can live on surfaces for days or weeks, highlighting the need for thorough cleaning in clinical settings. And we also have cleaning versus disinfection. There are two very different things. Cleaning does not equal disinfection. An effective contact time is crucial to ensure surfaces are pathogen-free. So let's talk about something you already know, or at least we think we do, the standard precautions and transmission-based precautions. We've been going on with this topic since our uni, but the truth is most breaches in infection control still come from basic precautions being missed. It's rarely some complex microbiology issue. It's usually gloves are not changed or PPE in the wrong order or isolation signage ignored. And those tiny slips, they're the reason outbreaks happen. And you know all your PPE dance, the gloves, gown, mask, goggles, and then realize we forgot the apron halfway through. So yeah, that's how transmission happens. So, standard precautions, as you all know, must always be practiced to protect everyone in healthcare settings, regardless of infection status, and transmission-based precautions, of course, contact, droplet, and airborne, with early isolation being crucial to prevent infection spread. So, we've talked about the science that we already know, the bugs, the PPE, the protocols, but I want to pause here and talk about the humans in the equation. Because at the end of the day, infection control isn't just about the right policy, it's about whether the people follow, and the compliance isn't just about a checklist problem, it's a culture problem. You could have the most beautifully written policy in the world, but if the culture in the team is we cut corners when we're busy or we don't speak up when something's missed, then that's policy is basically a wallpaper. So we've seen policies that are very nice, and some of them, we've been through other organizations that we didn't stay because most of the policies aren't followed and most of them are not implemented. Most of them are just fluff. So this is where culture drives compliance in infection prevention, and our leadership, and we role model. And that's why it's crucial for establishing our strong IPC practices. So encouraging an environment where team members can speak up without fear fosters accountability, and it improves overall safety. And the collective behavior of staff impacts clinical outcomes significantly. So communication and education. So here's something I've learned in aged care and clinical practice, that infection control doesn't fail because people don't care. It fails because people don't know. They don't know something that was missed. They don't know a risk was identified, or they don't know what needs to change. And that's why communication isn't just a nice to have. It's one of the most powerful infection control tools we have. Because if we're not talking about what's happening, we can't improve it. So the importance of feedback. Sharing audit results is crucial accountability and improvement. Ongoing education ensures that all staff are informed and up to date on infection control practices. The feedback loops are essential as they create opportunities to discuss strengths and weaknesses in IPC and driving overall enhancement care, quality, and patient safety. Now, I haven't worked much in the hospital setting. I work closely with aged care setting, but it is mandated for us that we all have IPC leads in every facility. Is hospital the same? So people who work in the hospitals? Yes. So we all have the IPC lead, and they're dedicated for a matter of a part-time or a full-time. It depends on how largely the facility is. And they have hours as well, and they have their own, own salary. Okay, so we have a little activity, a myth or a quiz. So I will be taking the paper. Thank you. And just in case you need a reference for this and where I have information, there is a reference. So just a little icebreaker as well. 8 questions. Is it a myth or a fact? So number 1, if you're wearing gloves, you don't need to perform hand hygiene. Myth or fact? Myth. These guidelines clearly state that hand hygiene is required before and after glove use because gloves can have micro tears and contamination and often occurs during removal. Question 2, alcohol-based hand rub is more effective than soap and water in most situations. Myth or fact? It is a fact. So I have the source here. In case, Mark can give you as well a QR code for the references. But these sources explain that alcohol-based hand rub is more effective and faster than soap and water in most scenarios, except when hands are visibly dirty or C. difficile spores are suspected. Question 3. Masks protect the person wearing them more than the person around them. Myth or fact? Myth. These sources emphasize that masks are primarily for source control, and they reduce risk of transmission from the wearer to others, although they do offer some wear protection as well. Question 4. Most infection in healthcare settings come from patient-to-patient contact. Myth or fact? Tricky part. It's a myth. The majority of hospital-acquired infections are transmitted via healthcare workers' hands, contaminated equipment, and shared surfaces, and it's not directly patient-to-patient. Question 5. Environmental cleaning is only important if there's a known infection. You all know it's a myth. Routine cleaning of high-touch surfaces is essential because many pathogens can survive for days to weeks, even when no infection is known. 6, antibiotic resistance is primarily a hospital problem. Myth or fact? It's a myth. Antimicrobial resistance is a global cross-sectoral issue, and it occurs in hospitals, aged care, community settings, and even agriculture. Q7, transmission-based precautions should be discontinued as symptoms resolved. Of course, it's a myth. Precautions should remain in places until the pathogen is cleared, not just until symptoms resolve. And some pathogens continue to shed after recovery. And last but not the least, hand hygiene. Hand hygiene compliance rates are usually above 90% in healthcare. Myth or fact? Myth. Most studies show compliance rates between 40 to 70% worldwide, even in well-resourced healthcare system. And this gap highlights the role of behavior, reminders, and accountability. So leadership beyond the policy. So this is a reflective section again. And we've talked about the science, the practices, the precautions, but now let's talk about the deeper leadership, because policies don't prevent infections. People do. So a beautifully written IPC guideline is just words, a page, until someone chooses to follow it. And that's a choice. And that action is us. Leadership. It's leadership from every single one of us, and no matter what our job title is. So it is a shared responsibility. Our IPC policies set the framework for care, but all staff share the responsibility for implementing them. Effective practice protects everyone involved, and by embracing IPC is a collective duty. Everyone contributes to better health outcomes and safety. So just final takeaways. So we've covered most of the basic IPC stuff, but from the science behind infection transmission to the power of hand hygiene, the role of culture, leadership, and even some of the myths that catch us out. But if you only remember a few things from this session, I want them to be just key points, because they're the heart of infection control, and no matter where you work. So if you remember nothing else, at least remember to clean your hands. That's it. So thank you.
Thank you, Lorraine. In the interest of time, we'll just save questions. You hanging around, Lorraine?
Yeah, hanging around.
I
I would love to listen to Sepsis.
You can catch Lorraine in the foyer afterwards. Thank you very much. I can confirm that's not just another infection prevention control lecture. With compliance rates as low as 40%, I think we can all take stock and take some ownership in this space. So
to be honest, I was nearly like changing my topic. It was like, ooh, the people that are in here already know this. But yes, thank you so much.
Thank you so much. Thank you. Thanks again, Lorraine. Okay, we'll just crack straight into our next presentation immediately. If you do need to go to the toilet, please feel free. But this next presenter requires no introduction. Of TikTok fame, clinical nurse consultant from Queensland, Rob Timmings, who is taking us on a sepsis deep dive. Make Rob feel very, very welcome.
Just give me a second. Lorraine, that was great. Thank you. It was a really nice interlude into my session, which sort of takes you to the next level from infection into the deep, dark world of sepsis. And I love that you started and finished with hand hygiene because it's so underrated. We have hand hygiene because the man who made it famous died from sepsis. Ignaz Semmelweis was a professor of medicine and obstetrician in Vienna in the 1840s. And he witnessed huge death rates from childbed fever in women who had contracted sepsis or group A streptococcal infections post-delivery. It was common of the day for the obstetricians to do autopsies and the delivery of babies all in the same shift, often without washing their hands, their instruments, or even changing their clothes. Gloves were not a thing in the 1840s. Remember, this was 20 years before Hans Christian Gram discovered that he could stain bacteria purple so that we could see them under a microscope. And so Semmelweis looked at his colleague who one day nicked his finger doing an autopsy, and this was a male doctor who died of childbed fever, and he thought there must be a link, and suggested that we should all wash our hands. And he saw the mortality rates drop from about 18% in these women to below 2% immediately, in the blink of an eye. The medical fraternity thought that he was mad, and they ridiculed him, and he went mad, and they locked him in an institution where one night he was beaten by his guards and died from sepsis because of the wounds that he received, just trying to get the medical community to listen to his message of wash your hands. So I'm dedicating this to Lorraine's great talk, but also to Ignaz Semmelweis. He's the man that really put hand washing on the map for us. Good afternoon, everyone. My name is Rob Timmings. I'm from ECT for Health. I'm a nurse educator, not a nurse consultant, clinical nurse. I'm a nurse educator based out of Queensland, beautiful north side suburb in Queensland called Ninghi, right next to Bribie Island. I've been teaching in the world of sepsis and emergency practice probably for the best part of 25 years as a registered nurse in Australia and Queensland. For 37 years, I've got some notches on my belt, so to speak. And today I've been asked to do a short presentation for you on sepsis. I didn't really understand the request. I don't do short presentations on anything, but I'm going to try and give it a crack in about half an hour for you. So let's talk through sepsis. Are you one of those clinicians who thinks sepsis is a really bad form of infection? We're going to touch on infection. We're certainly going to touch on the concept of fever, but I really want to drill down the message that sepsis is not infection. It is a separate subset of critical care. And if we could walk out of here with one piece of information that I would love you to hold very, very close to you, and that is that sepsis needs to be recognised early if we're going to have any chance at improving survivability. Australia has the best mortality rates in the world. 14% of Australians with sepsis will die from it, as opposed to 20 to 25% in the UK, Scotland, Ireland, and the US, Canada. So we're doing really well, but still 14% is a huge mortality rate for something that we can probably do better at. We're going to talk about understanding what sepsis is, at what point sepsis becomes septic shock. There's still ambiguity around that. And with so much research being done in the world of sepsis, I'd like to talk about what's trending, what's in, what's out, what's around the corner. So there's a bit of old in this, but there's also a little bit of new. So if we could call sepsis your house, consider this session as maybe re-stumping your house. First of all, let's talk about when too hot is too hot. It's too hot out there right now. Aren't you happy for the air conditioning? When we're looking at somebody's body temperature, we know that we have a normal range and we're quite comfortable with somebody with 37 degrees. We might call that normal. But realistically, when we have a look at fever, the concept of fever really comes into play once we rise our body temperature up over about 38. The international literature points at 38.3. So what would be considered to be hyperthermia? Because hyperthermia is not fever. Well, that's a temperature about 38.3. So you can see where fever is a temperature of 38.3, hypothermia, well, that's different. That's a temperature of 38.3. Then we have pyrexia. Well, what's pyrexia? Pyrexia is an elevated body temperature. Shall we say 38.3? But is pyrexia fever? Yes. And is pyrexia hypothermia? Yes. But is hypothermia and fever the same thing? No. So what's the fundamental difference between those two? Hypothermia is extrinsic. It's something that you get when you're lying in the Bali sun. You get when you're falling asleep on a sauna, when you're working outside in the heat, when you go to one of those rave parties like tonight and get too hot. You don't drink enough, you don't get enough shade, you overheat. Hypothermia is not an intrinsic process, it's an extrinsic process. It needs to be cooled down, there is no question. When somebody is hypothermic, we need to actively cool these people. But fever is different. Fever is a symptom. It's a symptom of an underlying inflammatory process, and inflammation is a normal process that is part of our healing. It's part of our injury repair process. We often associate fever with infection, but it doesn't have to be infection. We can certainly develop fevers through mechanisms that are inflammatory, that are not infection related. Indeed, large necrotic injuries, large burns, gravel rashes, and people who like to take a lot of skin off their body when they've been riding around on Bali scooters. My God, that's dangerous. Can develop fevers simply because of the inflammatory process. Fever is an inflammatory derived symptom. It's not a disease state. If I was to say to a fiery, should I be putting out the fire or waving away the smoke, what would be their advice? It's rhetorical. Of course, put out the fire. And the same applies to infection versus fever. Should I be getting rid of somebody's fever, or should I be concentrating on putting out the fire, getting rid of the infection? I'll let you make your own minds up. Hyperpyrexia is an interesting subset of pyrexia. It's when a body temperature now starts to elevate to a point that it becomes pathological in its own right. So where a temperature above 38.3 might be considered to be a pyrexia, once I get to a body temperature of approximately 39.5, that's when we start to see biological processes in the body start to become altered. Most importantly, and probably the earliest of those, would be a rightward shift of the oxygen-hemoglobin dissociation curve. As somebody starts to get very, very febrile, that's when we're going to start to see them desaturate. And so I'm often asked as a nurse educator in my field, Rob, at what point do you think that it's appropriate to give paracetamol to somebody that has an elevated body temperature? And my answer to that question is that it's not a number on a thermometer that I'm concerned about. It's a number on a SATS probe. When somebody starts to demonstrate desaturation secondary to an elevated body temperature, I think it's quite reasonable to go down the pathway of providing an antipyretic, specifically for the purposes of reducing body temperature. Of course, we'd never withhold something like paracetamol in cases of pain or discomfort or autism. Too soon? some references. I'll get a roast for that statement. So fever is a normal response to fighting infection. It's part of your inflammation, and if you can't have inflammation, you can't have healing. It's straightforward. It's a normal part of fighting infection. How does fever work? Well, there are sentinels all throughout your body. There's a specialised white blood cells that when they live in your bloodstream are called monocytes. They make up about 6% of your blood. When you look at a white cell differential, monocytes make up approximately 6% of your white blood cells. But some monocytes don't live in the bloodstream. These are specialised white blood cells that once they migrate from the bloodstream and into the tissues, they change their name to macrophages. Macro meaning big, phage meaning to eat. And it's these cells that will engage with pathogens and other molecules that come into your body that are perceived as a threat. You have a large amount of these macrophages that live in all surfaces of your body that come into contact with the outside world. So there's a lot of macrophages in your skin, within your respiratory tree, upper and lower respiratory tree, your eyes, your ears, and of course throughout your gut. Wherever a pathogen can come into your body, these macrophages stand as the first port of call. Chemicals that are on the outside of that pathogen, referred to as PAMPs, I'm not going to unpack that for you, but you can Google a PAMP. These PAMPs will attach to the macrophage and activate the macrophage to initiate the immune response. And it's through this process that if something goes awry, if the chemical message starts to go awry, then what we're going to see is an overwhelming septic response and a big release of a number of chemicals that these white blood cells release, referred to as cytokines. You've heard of the cytokine storm. The important players in the cytokine storm are these particular interleukins that you can see up here on screen. Interleukin 1, interleukin 6, to a lesser extent interleukin 8, and tumour necrosis factor alpha. These are chemicals that will initiate and stimulate and call the other white blood cells to the fore to start killing those bacteria or neutralising those pathogens. It's these same interleukins that are released by macrophages that will stimulate your hypothalamus in your brain to start to raise the body's set thermostat. So right now, the thermostat in your brain is keeping your body temperature at 37 degrees Celsius, irrespective of whether it's freezing cold in an air-conditioned room or whether it's stinking hot like a Bali sun. Your body temperature is going to stay the same because your thermostat is set the same. But in a case of infection or pathogens coming into our body, what our macrophages are going to need to do is upregulate their ability to do their job. And the only way they can do that is to stimulate an elevated body temperature. Your macrophages need it warmer. Quite frankly, they can't do their job at 37. So they will stimulate an elevation in body temperature specifically so that the immune system can be amplified, so that it can be ramped up. It casts aspersions, therefore, on the old-fashioned notion that when somebody develops a fever, we should squash that fever with an antipyretic substance. The hypothalamus raises the temperature in response to a formation of prostaglandins, specifically prostaglandin E2 is going to be the key player here. And it's prostaglandin E2's production within the hypothalamus itself that is shut down when we give somebody a medication like paracetamol or ibuprofen or any of the other non-steroidal anti-inflammatory drugs. It's for that reason that we need to understand that these antipyretics don't cool somebody down, they stop you getting hotter. It's fundamental to the understanding of why we should be using antipyretics, to understand that they don't make you cooler, they just stop you getting hotter. So if I switch off that prostaglandin message in my hypothalamus has no instruction from the immune system, and my hypothalamus will now just simply passively drop its temperature back to its preset norm. Can you see this is why we will see a fall in body temperature? But the patient who has hypothermia, because they fell asleep in a sauna, this patient is not going to get any effect whatsoever from an antipyretic. They need a fan and a nice cool blanket. Fever enhances the immune response, and it's something that we really need to recognise, that fever is not the enemy, fever is your friend. It is rarely harmful. So when is it harmful? When somebody has a sustained body temperature above 39.5, we start to see a shift in the hemoglobin dissociation curve. We start to see a reduction in the ability for red blood cells to transport oxygen effectively. What you're going to see in your patients is you're going to see desaturation start to take place. And what's the first thing that you want to do when your patient starts desaturating? You want to put oxygen on them. And that's a noble pursuit. But if my red blood cells don't want to carry oxygen, it won't matter how much oxygen you give to my patient, they're not going to pick up oxygen onto their hemoglobin. Do you see it's important for us to recognise that the desaturation that we might see with a hyperpyrexic patient is going to best be treated by reducing their body temperature at least down below that magic 39.5. This way their red blood cells will now be capable again of carrying will be capable of carrying oxygen and being able to oxygenate. So as that hemoglobin starts to dissociate from its oxygen, or oxygen starts to dissociate from hemoglobin in very hot patients, it makes a whole lot of sense that bringing that body temperature down so that we can resaturate the patient becomes more the priority than the number on the thermometer. That makes sense, yeah? SATs will drop despite the PaO2 being normal. So we can't be relying on blood gases to determine oxygenation status. Quite frankly, plasma-bound oxygen that we measure with the PaO2 is not the determining factor as to whether tissues are going to be well oxygenated. And this becomes important, particularly in hyperpyrexic states that we see in sepsis. When somebody's body temperature is hovering in the 40s, irrespective of the fact that their PaO2 might be adequate, they're just not oxygenating their tissue if they're dissociating from their red blood cells. Once we start to get to temperatures that are well into the 40s, 40.5 has been cited, then seizures and neurological injury become apparent, particularly in children and particularly in those that already have an acute neurological injury. It's the one reason why we do not want a patient who's in the process of an acute stroke becoming febrile. So the big question is, do I treat the fever or don't I treat the fever? And the answer to the question comes back to the notion of, do I wave the smoke away or do I put out the fire? Our focus really should be on the infection, not necessarily on the number on the thermometer. So with temperatures that are completely benign, completely harmless, up to and including 39.5, have a look at their SATs and treat them for comfort. Throw some Panadol at somebody or some ibuprofen at somebody if they're uncomfortable. There is absolutely no issues with giving something for comfort. But if we find ourselves giving medication to reduce their body temperature when their body temperature is benign, given the fact that this person has a body temperature that is elevated because they're trying to fight infection, it seems a little counterintuitive to want to try and suppress that. Once we see somebody start to become hyperpyrexic, then it is reasonable to consider antipyretics for the sake of bringing down temperature. Active cooling, including tepid sponging, seems to come in and out of vogue. And there's absolutely no reason why active cooling and tepid sponging shouldn't be used in somebody that is hyperpyrexic. I would highly advocate for it. I would be cautious in the child under the age of 3. Particularly those that are in that susceptible age group, potentially for febrile convulsions. The rapid cooling and or the rewarming of that child is far more likely to trigger a febrile convulsion than the temperature itself. So the take home is stop treating a number on a thermometer and start looking at the clinical pathway or the clinical situation. Are we cool with fever? Did you see what I did there? So let's talk about sepsis. What is sepsis? Sepsis is life-threatening. kills people. 14 to 20% of Australians every year with sepsis will die from it. This is the international definition of sepsis, but it's wordy, it's gobbledygook. Let's try and put it into some perspective. Sepsis is life-threatening, organ failure. And we can put a full stop right there, and that's enough of a definition for sepsis. It's life-threatening organ failure. Now, we can qualify it by saying it's life-threatening organ failure because there was a dysregulated immune response. In other words, your immune system got the wrong messaging. And instead of attacking the pathogen, it started attacking your organs. Something went wrong with your immune system signaling. We don't know why. We know that it was a chaotic cytokine storm, but we can't pin it down in every patient to any particular process. It almost certainly has nothing to do with the pathogen. It's all about your immune system. But what triggers your immune system is, of course, that initial contact with the pathogen. So you can see that infection comes into play here as a trigger mechanism, not as the disease of sepsis itself. So if I could be so bold as to point my whiteboard marker, which I'm going to pretend is a weapon that would fire a projectile, and I could pull the trigger. Bang. It wasn't an overwhelming gun. Bang. Now a bullet has left the chamber of this gun, and it's now travelling across this room, and it's eventually going to hit that wall at the back of the room. The bullet is the sepsis. The trigger that I pulled, that's the infection. Would cutting the trigger finger off now, after the bullet has been loosed, stop the sepsis? Shall I ask the question again? Would giving me an antibiotic now do anything for my patient in sepsis? I just want you to stop and think about that. Because if sepsis triggered the release, if infection triggered the release of that bullet, if infection triggered the release of that sepsis, then stopping the infection right now doesn't change the fact that that bullet has still taken flight, and damage control is going to be our next option. Does that make sense? So our focus needs to be on what happens when that bullet hits its target. The damage to the wall at the back of the room in this analogy is going to be your organ failure. Would it make simple sense that we need to be focusing, if we're going to save lives, on the organ failure component, the sepsis fallout, less so on the infection that triggered it in the first place? Does that make sense? So there have been some changes to our understanding of the mandate that we need to give antibiotics in the first hour. There's not a clinician in the room that hasn't heard that mantra. Antibiotics inside the first hour for a suspected sepsis, yes? And well, that may be true in the context of somebody with septic shock. Certainly that time to antibiotics has become less emphasised over the last 5 years in the literature. The emphasis now is inside 3 hours. It's far more important to stop that damage than it is to stop the fact that the bullet's already been fired. Should we be focusing on closing the gate after the horse is bolted, more so than rescuing the horse or the damage that's going to happen from the bolting of that horse? Do you see my analogy there? Pathophysiologically, the same cytokines that are released during an initial inflammatory response are those that are thought to be responsible for our sepsis response. That bullet, that damage that's being caused, starts with widespread vasodilation. White blood cell released chemicals, cytokines like interleukin 1 and 6, to a lesser extent 8, and tumour necrosis factor alpha, these initiate and switch on the mechanism for histamines to be released and other leukotrienes to be released that cause early widespread vasodilation. If all of my 5.5 litres of blood that should be shared adequately between my venous network and my arterial network, perfusing my heart, lung, brain and kidneys, my vital organs, should suddenly be redistributed out into my periphery because of widespread vasodilation, then what I'm actually receiving is a hypoperfusion injury. Can you see my kidneys will fail as a result of hypoperfusion? My cardiac output will reduce as a result of hypoperfusion. My cerebral events, my cerebral cognitive, I'm having some now, maybe I'm septic. It's that bloody dodgy Bali tattoo that I got yesterday. Can you see, you think I'm joking. Can you see that if I'm hypoperfusing vital organs, then typically we're going to see classic symptoms of sepsis secondary to that. If I'm hypoperfusing my brain, then altered levels of consciousness will be inevitable. If I'm hypoperfusing cardiac cells, then hypoperfusion of my heart and therefore a drop in cardiac output and blood pressure will be inevitable. I'm going to reduce my urine output if I'm not circulating enough blood through my glomerulus. So an acute kidney injury secondary to this hypoperfusion will be inevitable. If I'm going to start hypoperfusing my liver, then I'm going to start to see an overactivation of certain liver enzymes and an underactivation tend to go. An underactivation of my ability to be able to manufacture coagulation pathways, coagulation proteins. As somebody starts to become more and more vasodilated, capillaries now start to leak. And when they start to leak, plasma volume drops. Now, I want you to think of what blood is. It's soup. It's cells, it's proteins, it's electrolytes, all in water. And the smallest of our particles, not the proteins or the cells, but the water, the electrolytes, the sugars, the other small molecules that are in my plasma, they're going to start to move out through those leaking capillaries in my tissues. And what's left behind is not only a reduced volume of blood, a hypovolemia, but a hemoconcentration. That blood literally becomes more concentrated. It becomes more viscous. And as it becomes more viscous, that hyperconcentrated, viscous, sticky, honey-like blood isn't wanting to travel through the very smallest of capillaries that are used to perfuse your heart, lung, brain and kidneys, your vital organs. So that blood prefers to stay out in the larger blood vessels rather than go through those very thin little capillary beds. And through that mechanism, we start to become hypoperfused in those tissues. Now, the inside of the endothelial walls of all of your capillaries now start to shed. They start to break down. And because we're breaking down those capillary walls, we're starting to see the release of a number of damaged cellular components and particles that are being released into the tissues, into the bloodstream. And that's going to further initiate and trigger that clotting, widespread clotting cascade. As clotting starts to take place and platelets start to clump and stick to the damaged inside walls of our arteries and our veins, and more importantly, our capillaries, that now starts to trigger the coagulation pathway. Early on in sepsis, we initiated the big release of a large amount of fibrinogen into our blood. So the fibrinogen is there and ready just to be switched on to turn into fibrin. Now your fibrinogen turns to fibrin. It becomes little stringy strands of what looks like dental floss all throughout the blood. And as red blood cells try and squeeze past this network of fibrin mesh clogging up on inside of your blood vessels, those red blood cells now fracture and split and are broken apart. We start to become hemolyzed. What's happening to somebody's coagulation or blood flow in those tissues? What's happening to the capacity to carry oxygen in those tissues if I'm shredding my red blood cells and my capacity to carry oxygen? Sepsis kills, and it kills quickly. And we need to preemptively strike the damage before the patient becomes so unwell that they're in a state now of shock. Because once we see persons go from sepsis into a state of septic shock. It's at that point mortality rises from anywhere around the 14 to 15% up to 80% once in shock. Often in the conversation around sepsis, clinicians will talk about a warm sepsis and a cold sepsis, a warm shock and a cold shock. And it's fundamental to understand that warm sepsis and cold sepsis has nothing to do with body temperature. I can have a cold sepsis and be febrile, and I can have a warm sepsis and be hypothermic. Body temperature is not the indicator that we use to measure whether somebody's in a state of warm sepsis or cold sepsis. Feel your arm. Feel the person's arm next to you with their permission. Only good touching. If they're pink and they're warm and they're perfused and they feel warm to the touch, that vasodilated phase in sepsis, then it's referred to as warm sepsis irrespective of body temperature. But if they're classically shocked, pale, cold, clammy equals shock, that's cold sepsis. Pale, cold, clammy equals shock. Pale, cold, clammy equals shock. Pale, cold, clammy equals shock. When my patient in sepsis is pale, cold and clammy, they're in early on, when they're vasodilated and warm, what I want to do is I want to vasoconstrict. And of course, this is where pressors come in very, very early. We love our noradrenaline or our norepinephrine. We're underwhelmed by metaraminol or aramine. We're underwhelmed by vasopressin. I don't even know where to find it in our cupboard at work. Norepinephrine seems to be where the game is at. And when it comes to a formal shock, we need to increase the inotropy or the force of contraction. Then, of course, we need to move away from something that's purely a vasopressor and into something that's a bit more inotropic. And this is where adrenaline would come into play. So what are the 4 R's of sepsis? Well, the first one is to recognise sepsis. Remember, sepsis kills. Early recognition is part of our damage control. We need to respond. And certainly the conversation has been around getting antibiotics in early, but we've to date have not convincingly been able to find out how early is early enough. Studies out of Melbourne have suggested that if I can give antibiotics in pre-hospital medicine to my patient when I arrive in my ambulance to their home, if I suspect sepsis, to actually give antibiotics based on a protocol, has not improved survival. When we've given nurses the ability to be able to administer antibiotics at the triage desk before they've even gone inside to have their first set of obs, we're cannulating and giving that first dose of IV antibiotics at triage. That has not suggested that there's an improvement in survival. If we've given antibiotics in the first hour, that hasn't improved survival. And if we've given those antibiotics in the first 3 hours, we have an underwhelming statistical benefit. We just know that after 3 hours, our patients do worse. So the conversation that we're starting to think about now is, do we really need to give antibiotics inside the first hour, or is antibiotics perhaps not the most important of our features when that patient first arrives? It's going to be a hard one to shift away from. I totally get it. I think what we really need to do is some crystal healing. You think I'm joking? Pressors, absolutely, we know, are going to improve that state of shock by redistributing blood vessels, distributing blood back into my core circulation to perfuse heart, lung, brain and kidneys. It makes absolute sense that pressors are going to be here to stay. Just what pressor we use is up for debate. Whoever is the pharmaceutical company with the loudest voice. Norepinephrine seems to be the winner at the moment. But please don't discount crystal healing. 20 to 30 mils of crystals. You know the crystals I'm talking about, sodium and chloride and potassium and magnesium and calcium, all dissolved in bags of water that we call crystalloids. You thought that I was from Curammeng up in... the hinterland or Nimbin. Yeah, wrong sort of crystals, right? Look, the rocks are pretty, but please don't think that rubbing somebody with rose quartz is going to save their life. They need crystals dissolved in water, and crystalloid solutions are where it's at. How much crystalloids? We don't really know. The Americans like their 30 mils a kilo. We like our 20 mils per kilo. And in sensitive populations, we like our 10 to 20 mils per kilo. All we know is that the literature over the last 5 years is pointing us towards liberal use of crystalloids, not conservative use. So if we've given enough fluid, we think we've given enough fluid, give more fluid. We can always get it back. But if we don't give enough, then we're not going anywhere with our patient. And of course, refer. These patients are sick. Like, they're fully sick. Fully sick. So what are our criteria to recognise sepsis? Well, everyone's familiar with the Q-SOFA. Looks at those 3 criteria of hypotension, altered level of consciousness, and an elevated respiratory rate, tachypnea. The addition recently in 2018, so we got Q-SOFA given to us in about 2016. In 2018, they said, well, Q-SOFA is not good enough, we need to add lactate to that. So with a lactate level above 2, where normally your lactate would be expected to be 0.5 to 1, a lactate above 2, it would be absolutely reasonable to say, yep, this is a definite marker for this patient moving from sepsis into a state of shock. But our Q-SOFA L is not sensitive enough. And so there tends to be a trend towards using the NEWS2 criteria, which includes all of those 3 elements of Q-SOFA. They're in the 3 asterisks that we've got here. But it also includes things like oxygen saturations, whether the patient needs oxygen to maintain their saturations is a key marker. What is their body temperature? Are they hypotensive or are they still pyrexic? And heart rate. We also need to be looking at things like level of consciousness with a little bit more clarity. The old days of AVPU have been reimagined, and we now have a category of C that sits in the middle of that. So alert, confused, verbal, painful response, or unresponsive. When we look at our 4 Rs, we're looking at our assessment of our patient using the classic ABCs. We want to have a look at vital signs and blood sugar level and absolutely skin indicators of shock. How do I know somebody's in shock? Skin indicators. Pale, cold, clammy equals shock. I can't hear you. Pale, cold and clammy equals shock. Does the patient have a rash? Who's seen a rash like this? A purpuric rash like this is not a rash. Don't ever look at this and think that you're looking at a rash. This is bleeding under the skin. This is coagulation failure right here. Get a history of contact, and of course, if there is a different coloured blood tube that you can fill it. You know the one we don't fill is the one that they are going to want. So we're going to get urines, and we're looking at blood cultures, and we're looking at sputum cultures and lumbar spine stabs and white cell differentials. The emphasis is absolutely on antibiotics. Inside 1 hour has been the caveat, but that inside 1 hour is now really confined to a state of shock. If my patient's in shock, how would I recognise that? Pale, cold and clammy equals shock. You must have been to an ECT for health talk. Then antibiotics are absolutely required. 3 hours is reasonable for those that aren't yet in shock. If we've got a true pyrexia of unknown origin, then it's reasonable to start thinking about meningitis. We're not sitting on these patients for too long. We would give empirical antibiotics that would be used to kill anything. And so if we're going to be treating for meningitis, even if we have no evidence of meningitis, then it's essentially napalming whatever could be the trigger here. So we love ceftriaxone, we love vancomycin as an adjunct, and I think there's so many medical teams out there that are favouring pip-tas. Are you seeing more and more pip-tas being used? And I think it's just because they like saying pip-tas, because there's really not a lot of data to suggest it's superior to everything else. Commonly needed, this crystal infusions are going to be required. So we're favouring balanced crystalloid solutions rather than the dangerously unbalanced normal saline. If there's one thing we've learned about normal saline is that it is not normal. So when we start to talk about volumes, we're looking at around the 20 to 30 mils as an initial bolus. Now just put that into perspective. A 70 kilo adult's getting an initial bolus of 20 mils per kilo of a balanced crystalloid. That's 1,400 mils, bang, straight in. That's a lot of volume. And it's not unusual to see within the next 12 to 24 hours that these patients will be fluid loaded phenomenally, up to 200 mils a kilo, just to maintain normal blood pressure. Now, if I'm fluid resuscitating you and you're not maintaining your mean arterial pressure at 65, by definition, you have entered a state of septic shock. So an inability to maintain normal mean arterial pressure above 65 despite IV fluids is fundamentally our definition of septic shock in this case. We need to correct blood sugar levels. If I'm pouring fluid into your blood, I'm diluting what is already the glucose that you have in there. In children, this is catastrophic. They will drop their sugars like a stone. In adults, we tend to become hyperglycemic. As we ramp up our catecholamines and our cortisol response, we actually break down and release a lot more glycogen. It's expected in shock that we will see an adult start to have a rise or an elevation in blood glucose level, despite dysglycemic conditions like diabetes. But in children, they drop their sugars like a stone, and we need to maintain blood sugar. So not just balanced crystalloid solutions when we fluid resuscitate children, but crystalloid solutions that are enriched with glucose. So what is new? Well, we've already talked about some of this stuff. I'll quickly flick through these and then we can finish up. Antibiotics have moved from the 1 hour mandate to try and get coverage inside 3 hours. Certainly inside the 1 hour for somebody who's already in a state of shock, but trying to get coverage inside 3 hours is quite reasonable. The addition of hydrocortisone over the last 5 years has started to develop a lot more interest. If it's your immune system that's trying to kill you, why don't we just shut down your immune system? Why don't we just give you some hydrocortisone, or fludrocortisone is getting a bit of a look in, and we can shut down your immune system. It's your immune system that's killing you right now. It's not that pathogen. The infection's not killing you, it's the sepsis that's killing you. So let's take your immune system out of the equation. Let's stop that cytokine storm by shutting down your immune system. We can look after the antibiotics for you. We can kill the infection for you. Right now, we want your body to stop attacking itself. Do you see the sense, therefore, of giving something that's profoundly immunosuppressing? And fundamentally, we also know that when we give something like hydrocortisone, it actually assists our catecholamines to do their job better. A patient who's getting norepinephrine to try and maintain mean arterial pressure, it's easier to maintain mean arterial pressure in the context of them having hydrocortisone on board. So there's a lot of movement and excitement towards the use of hydrocortisone, initially 200 milligrams a day, for these patients who are septic. So what's out? You've probably read and heard about the whole vitamin C discussion. It's been looked at, the Lovett trial looked at it in 2022 and essentially said, yeah, nah. We've got to stop thinking that high-dose vitamin C IV is going to do anything for our sepsis patient. It's not only proven to be underwhelming in its response, but it has been demonstrated to worsen mortality. So vitamin C, probably more harm than good. Normal saline is not the crystal of choice. We need to be choosing something that's balanced. And when we come down to fluids, liberal far more than conservative. This is not meant to be a political statement. What is controversial and new? Well, it's AI-assisted detection, using AI. Cautious adoption, but it seems like a good idea. It's access to good AI programs and good AI protocols that are starting to become the bottleneck. Siri and Alexa rate it 5 stars. ChatGPT's not so sure. What's around the corner? Well, maybe we can look to the other autoimmune discourse, and that's that around oncology, the management of cancers by targeting certain cancers, immunological signatures. Perhaps we can use phenotype-driven precision management to look at every patient who's got sepsis by running blood through an analyzer that's going to give us a very, very descriptive target of which are the interleukins and which are the cytokines that we need to switch off, and then target managing our patients with the right chemicals to shut down that immune response. Not eliminating indiscriminately their immune response like hydrocortisone does, but targeting specifically that patient's septic trigger and switching that septic trigger off before it becomes a state of shock. Not all patients navigate sepsis the same way. So think the way that oncology matches treatment to diagnosis. Perhaps into the future we can start to look at models where we're able to map treatment for sepsis to the patient's specific diagnosis. So in closing, I just want to say thank you very much for attending my talk this afternoon, and for those that attended the rhythm interpretation workshop of mine this morning. I hope that you enjoyed it. I want to thank the organisers for this. Remember the 4 R's in sepsis, to recognise, respond and resuscitate, and of course to refer. These people are very, very sick. If you're not already a social media person, consider following us on social media. My name is Rob Timmings. I go by the nom de plume of ECT for Health, or just plain old Nurse Rob and Amy. Thank you very much, folks. I'm happy to take questions if time permits.
Nurse Rob, thank you so much. That was absolutely invaluable, such an important topic. We don't have time for questions at the moment, but Nurse Rob will hang around for questions in the foyer. We're just going to take a 5-minute break. Nurse Rob may even agree to show us his new tattoo. 5-minute break, everyone. Be back here in 5 minutes. Thank you, Nurse Rob. Nurse educator. Hey, thank you. Okay, our next presenter is absolutely no stranger to the EMS conferences, presenting at multiple of them. We are really, really lucky to have from Brisbane, Kim? Gold Coast, sorry, the sunnier part. From Gold Coast, Queensland, please make clinical nurse consultant Kim Lappin make her feel very welcome. Thank you, Kim, for being here again.
Everybody hear me? Is everybody... Maybe if we can all move forward, because I do like a bit of interaction. There's no role play, I promise you that. But I suppose I do have some interactive things at some part of my talk. So it would be good if we could move a bit more forward so there's not so much gap and people at the back. Can we do that just to make things easier? Thank you. While you do that, I might as well start because I know that time's limited and I know we've got the closing party. So firstly, Rob, you are a hard act to follow wherever he's gone. It's always nerve-wracking coming on after Rob. But firstly, I'd like to thank EMS yet again for inviting me back, Dylan and Quinton, and now Mark and Patty, all the sponsors, and of course you guys for turning up. So my name is Kim. I'm a clinical nurse consultant. I specialise in mental health. And I've worked in mental health for 35 years, and I'm going to stop saying it after this year because it makes me feel really, really old. I suppose a bit about my background. I've specialised in all facets of mental health, as well as private practice, and I always come back to the frontline service. I love my work on the frontline. I'm currently one of the QAS mental health co-responders on the Gold Coast, and that's a role that I absolutely adore. My daughter that normally presents with me, who's also a clinical nurse consultant, couldn't make it, so Sarah, who's one of our nurse practitioners from the Gold Coast in ED, has nicely stepped up for me. So Sarah's got 25 years as a nurse, 2 years as a nurse practitioner. And I suppose at Gold Coast, I think all departments, we tend to work in silos. Do we agree? Yep. So at Gold Coast, we're really trying to break down those silos. So part of doing talks together or looking at what we can put in place for our patients is part of what we do. So I thank Sarah for coming and her husband Greg, and I'd like to wish them a happy 31st wedding anniversary. So everybody wants to give them a cheer because that's like a life sentence. Okay, so I suppose I would like to know a little bit about the crowd. So who here works in ED? Great. Who here is a paramedic? Anybody allied health? Great. Anybody mental health? 1, 2? Great. Anybody that specialises in neurodiversity? Bummer. Normally there's always one and I can deflect all those hard questions to them. So a bit of my background, as I said, I have worked in private practice, more recently in a quite affluential neurodiversity private practice. Neurodiversity isn't mental health, but I suppose we see it a lot. Would we all agree that neurodiversity is becoming more of an occurrence in our practices or that comes into our department? Yeah. Who feels confident in working with neurodiversity? Yeah? Okay. So I'm not going to do lots of research. I'm not going to give lots of data. What I really want to do is just reflect, just to refresh your memories around what neurodiversity is and why it's problematic in our departments. You'll see there's a table at the front. So this is the interactive bit. So on the left-hand side of the table, there's some neurosensory toys. So I'd like you all to come up and just choose one. Just something that you think that would suit you. Because everybody's different in what they like from a neurosensory perspective. This talk was actually planned for Thailand. Unfortunately, I ended up in a Thai hospital and couldn't deliver the talk, so it's now been diverted to Bali. And I do not want to take any of these toys home with me. And these are just examples of what we can use. Again, these are just purchased off things like Temu, very, very cheap. Ideally, they're not things we can use in our departments, again, because of infection. But what we can do is have our own toolbox. Take 2. Take more than 2. Oh, that's for later. You can have the ice later. There's a trick to the ice. And I'm sorry for those online that can't get a sensory toy to distract yourself with my talk, but maybe just watch the others playing. And because Rob is that hard act to follow, I've bought toys. Rob's TikTok, I'm the toy person. And normally my daughter is the IT person, so please put up with me if I don't do the slides correctly. And if you don't like your toy, feel welcome to come up and grab another one. And again, as I said, if we're working in a department because of infection, we'll be choosing items that are not going to spread that infections, items that we can give away, items that we throw away. I often have my own toolbox of sensory items when I'm working as a QS mental health responder, and they come in handy. Okay, so let's get started. So I just thought to start with, we'd put a little bit of a snapshot up about Gold Coast. So if we look at the 2024 yearly wrap, we had 127,618 presentations, and that was up from the previous year. Now, at Gold Coast, we put in place a lot of ED avoidance strategies. We have our co-responders, we have our nurse navigators, and we also have opened up a crisis stabilisation unit where we can take our mental health patients rather than the ED. Also, when we have significant events like we host schoolies, the car racing, I cannot remember what it's called, I'm not into cars, but whatever's happening in the next week, we make sure that we have personnel down on the ground so those people don't have to come into ED if we can help it. Sarah, was there anything else that we put in place? Oh, the marathon, yeah. So any...
later, which tends to be New South Wales and Victoria.
Yep. And what we find, I don't have the numbers in my head, but we have a lot of people turning up to our tents when we put these teams on the ground. And again, that prevents these people coming into our ED. If we didn't have these strategies in place, we would be inundated if you look at our figures. So neurodiversity, really it just, as it says, it refers to neurological conditions, ADHD, ASD, dyslexia, and these overlap. And I'll show you a couple of slides in a minute as to how complex it can be. And again, we're not the ones that will be diagnosing, but again, if we know that there's neurodiversity or we get a sense of that, then we need to understand what lies behind that in order to best treat our patients. I'm going to try and look at the best practices, considerations, effective communication, and that is the key. It's effective communication. Okay, if you can take anything out of this, it's the effective communication, because we need to communicate differently with our neurodiverse community. And in saying that, the community that we see that presents to us is a snapshot. There's lots of us out there that are neurodiverse. I say it's a superpower. Lots of people that work in health have neurodiversity. That's why we do so well at what we do. Okay? Thanks, Rob. I've just had a tendon transfer, so I'm playing with my toys. I can't hold things properly in my hand as yet. So we've done a Slido, and I just want to see if you've got your mobile phone, just see if we can see if it works. This is my first time at trying to do Slido. Is it working, guys? Yep. Okay. If it doesn't work, there's another QR code. I think I've got 3 QR codes because I was being over of the worrier that I am, thinking, oh my God, how are people going to log on? And another one. We'll go back. Oh, now I've gone too far. How do I go back? I need to just go back to. So are you on the quiz? Have you all got on there? Yep. So if you can register and then answer the questions on the quiz. Yeah, that one will be fine. And then when the slide. Yeah. So I'm going to get some IT help so we can get those results up on the screen. Have you all got the questions on there? Is it working? Oh, it's got all the answers. Okay, we'll skip that. Skip it. Skip. Okay, so if you look at neurodiversity, it's quite busy, isn't it, this slide? Yeah? Neurodiversity is busy. It overlaps. It's not an easy thing to diagnose. And I'll get into questions later. People always ask around the influx of people being diagnosed. Happy to answer questions around that. But we do have the dyslexia, we have the ADHD, Tourette's, ASD, dyspraxia. It's all interwoven. And so the art when we're diagnosing, again, it's not for us to diagnose, but it's knowing what the symptoms are and how we're going to best help that person. And not everyone is alike. So neurodiversity. There was a sociologist, Judy Singer, who coined the term, I think in 1990, am I correct? Yes. And it describes people with different characteristics, neurodevelopmental disorders in a non-prejudicial way. And that's the key. Neurodiverse is not, it's not something to be prejudiced about. Yeah. Having knowledge helps us move the focus and impairments towards everybody's abilities, not their weaknesses. And it's thought up to 15% of the population are thought to be neurodiverse. So whilst you're listening to this talk, I want you to think of maybe a problematic patient or somebody that comes in regularly that plays to mind when I talk, because I do have some case studies, but if everybody's keen, I'm keen for somebody to throw forward a patient and we can try and work on that patient together to see what we've learnt from here. So ADHD. So everybody's aware of ADHD? Seeing the news a lot lately. So it affects our executive functioning, self-awareness, inhibitions, working memory, non-working memory, emotional regulation, and that's what we see in ED a lot, or when we go out with the ambulance. And that planning and problem solving. So researchers agree that EF doesn't occur all at once. Yeah, it's the first three tend to develop together, which is that self-awareness, self-restraint, and that visual imagery within the first 5 years. And then we have self-speech will then develop. So the remaining functions as on the screen, that's self-motivation, self-directed emotion, problem-solving, and planning are forms of self-play. And they derive when people take new information and they restructure it in their minds. And it creates multiple options and invent new ideas. So that's how our brain works as we grow up, yeah? And we know if our early EF is impaired, our later EF will be as well. So our executive functioning is harder to diagnose as we get older. There's 7 core EFs that are used together to form those dimensions: self-restraint, regulation, time management, which is my downfall. I'm very poor on time, hence these lovely guys will give me a cue when I've spoken for too long, because I tend to digress as well. That's self-organisation, problem-solving, self-motivation, and emotional regulation. So if we look around the facts around time management, if you just want to have a look at those slides, it will clearly tell you around our ages as to when we accrue that time management. So it makes sense, doesn't it? Young children only think about the present. If you think of a toddler, it's only about the here and now. Early primary school, 12 hours. Later primary, 1 to 2 days. Adolescence, 3 to 7 days. University, 1 to 3 weeks. Now 30s, 2 to 3 months. Okay, and ADHD is 30 to 40% delay in that time management skills. And as we get older, it's harder. I talk a lot about scaffolding, especially when I was working in private practice with my neurodiverse population. So scaffolding is around how we manage our deficits, how we manage our symptoms. Lots of us have learnt ways to manage it without even know we're learning those ways. For example, if I'm in a meeting, I've learnt to doodle. I scribe on a pad, I doodle, because that's telling my brain, shut the F up, because I don't want to interrupt. Yeah? Because in the early days I would have bounced in, I would have given my opinion, but now that's my cue. Another trick that people often use is I've learnt to set a time, because I will hyper-focus to the nth degree. So I need to have a timer going. It's time to stop, it's time to have a break. But in saying that, the hyper-focusing is good in our role because we do well when we do it. So to assess ADHD, and it's a bit of a conundrum here for me because I think too many people are easily getting assessed on a one session. To assess neurodiversity, it takes more than one session. I think, might be a bit controversial, but I think lots of people have learnt, our doctor friends and our specialists, there's lots of money. People are coming in seeking to look at that diagnosis. One session doesn't cut it. To be diagnosed with adult ADHD, you have to have proof that you had ADHD as a child. Yeah? In the clinic where I worked, it was very much involving the whole family, the parents, the partners, looking at those school reports. So it wasn't just a 1 hour session and bang, you've got a diagnosis and you're going to get treatment. It's really hard to pull it apart, and in future slides you'll see why. Just one other note, we know that if we identify early, especially with our children, it can prevent those diagnoses of ODD and conduct disorder. So often kids get diagnosed with oppositional defiant disorder, conduct disorder, but underneath that lies neurodiversity, and people just don't acknowledge it or understand what's happening for that child. So then they get labelled. So if we break it down, whenever I was doing an assessment, I'd break down my assessment. So I'd be wanting to ask the patient around their executive functioning. So break that down. What's your working memory like? Explain what working memory is, non-verbal working memory. What happens for you? Listing all those symptoms, procrastination, distraction, how much does it affect your life? And that's important because when we look at the efficacy of medication, we want to see how much that medication is having a positive effect. Because if it's not impacting, then we need to look at, what else is happening for that person? And lots of misdiagnoses can happen. So lots of people who have been misdiagnosed as borderline personality disorder, emotionally unstable personality disorder, actually have a lot of neurodiversity sitting underneath that. And unfortunately, you get a label of that in our system, and that's all that people see, which is my big beef. If somebody's got a label of personality disorder, all of a sudden that's all they see. They come in and it's that person again. They're dysregulating. Well, we need to look at why. Why is that person dysregulating? Otherwise, we're just putting a Band-Aid on that person. And comorbidities. So 90% of children and 85% of adults are diagnosed with at least one other psychiatric condition. That's a large amount. And around 50% of those children with ADHD have at least two coexisting conditions. I'll get Sarah up now to write on the whiteboard, because I want you guys to call out what do you think some of those comorbidities or coexisting conditions may be for adults and children? I think she's just getting a pen, but anxiety, absolutely. I said this at Japan at one of the conferences. My children say when they look back, every time you say absolutely yes is amazing. So in Japan, they were all having a drink whenever I said absolutely yes, but we won't do that because it's a bit not kosher. So anxiety was one. Anything else? Depression? Yep. Yep. ODD? Yep. OCD? Yep. Sleep disorders? Yep. Tic disorders? Yep. It's also sleep disorders too, but yep. F&D? Yep. POTS? Yep. Did you get that one, Sarah? Barbara? No wrong answers. Anybody else can have a guess? Yes, Yeah. Ehlers-Danlos. Ehlers-Danlos, my daughter has Ehlers-Danlos, and interesting enough, she's now 30. When she was diagnosed, she was very young. She was 13, and we're at the paediatrician, and she pulled out her skin and said, "Why is my skin so stretchy?" And he went, "Oh my God," because it was really stretchy. And then we were sent to, all these different people, and they said, "Oh, it's nothing, doesn't affect anything." Now we know it absolutely does affect everything. So sometimes we get told these things and we take it for granted. Okay, I just listed some of those, which you guys have said. So substance use disorders is another really big one. Our sensory processing, eating disorders. Eating disorders is largely linked with neurodiversity, especially binge eating disorders. So we know there's behavioural challenges. So they have difficulties with tasks and boredom. Especially when we treat adults, it's interesting that a lot of adults that we were treating that were diagnosed a lot later had multiple relationships, multiple marriages, multiple shifting from one job to another. They'd get bored and they'd move on, quickly. They couldn't sustain. And this is the one that probably affects you guys the most, the impulsivity and emotional regulation. So we see it, as I go out with the ambulance, we get called out, a child dysregulating. They're saying they're suicidal. Half the time, by the time we get there, that child has calmed down. Unfortunately, if we don't get out there and have somebody with some knowledge, those children are then brought into ED. So ED is not a place for neurodiversity. So who wants to sum up what an ED environment is? Noisy, loud, bright. Yep. So it's overstimulating. Yep. So the key when we go out, and again, it's not a mental health disorder, but it's about trying to regulate the person, and it's more about teaching the families or the systems how to manage that child in that environment. Because we bring them in and we're just going to dysregulate them more. Challenges. So executive functioning refers to a set of the cognitive skills like planning, organising, initiating those tasks and problem solving. That's difficult for a person with neurodiversity unless they've learnt how to manage that. And as I said, lots of us have it and we've learned how to manage it. Maybe it's a subconscious thing that we've learnt along the time. Like none of us had to all go to therapy to learn these skills, but people can learn these skills. The sensory overload. So it's sensitive to that sensory stimulation, as you guys said, exactly what an ED environment is. Yep. So we're going to re-trigger these children. And when I get into future slides, I'll talk about trauma and how that interlaps, and again, the impact that ED environments have. So communication challenges. So especially children, but they struggle to verbalise their needs. Yeah, and we know that children, until we get to the age of 24, our brains aren't wired to communicate what our needs are. Okay, so we often act out to get our needs met. It leads to misunderstandings. It further exacerbates those problems. And they might resort to behaviours like tantrums and refusal to really settle with their emotions. And again, that struggle. So they struggle from one activity to another. They become resistant or agitated when asked to switch tasks. If you've got a child with ASD and they're set on their task that they like, to ask them to switch off that can cause an outburst. Yeah. So it's about teaching the parents, especially with children, how to manage that. How to say this, we're going to have so much time on this activity, but then that's going to be switched off. So lots of what we see out there is a lot of people that are struggling to manage those behaviours. And as I said, there's lots of people with neurodiversity that do not have those behaviours, that they've learnt to manage them. So I'm not saying everybody with neurodiversity has these symptoms. So our stats. So we know that youth with ADHD are 25 times more likely to self-harm. So that's massive. And we know that research says that females with ADHD are 2.5 times more likely than their neurotypical counterparts to engage in that non-suicidal self-harm, and 3 to 4 times more likely to contemplate or act on those suicidal thoughts. And understanding the underlying factors impacts a person's behaviour and can help them develop strategies better. So we tend to go out, the person's acting out, they're brought in, but nobody's teaching them, nobody's linking them with the services that teach them. So they're often our frequent presenters. We go out time and time again because they don't get linked, it's put down to a behavioural issue. The parents aren't given the resources, and parents are crying out for those resources. So management strategies. I'll just let you have a look at that for a minute. Do we do this well in ED environments? No. Do we do it well when we arrive as QAS or ambulance? Because, as I said before, this is the problem, solve it. You're not meant to spend time. You've got another job to get to. So the strategies. You have to focus on the feelings. What's happening for that person? Ask them what's happening. Why are you so upset? Just tell me. I might be able to help. Ignore the challenging questions because they're going to throw them at you. Move on to another area where you can communicate with that person and set limits. And this is hard for parents to do. So often talking to parents is about linking with services to be able to learn these skills. And I get it. There's no services out there really in a public forum for lots of these families to connect with. Unless you have a lot of money, most of the neurodiversity clinics will charge an absolute mint. Choose wisely what you insist upon. I used to say that even raising children, all my children in their 30s, but pick your battle. What's worth battling? Because if you battle over everything, you'll be the one that will be in ED with, emotional crisis, not the child. And allow them silence to reflect. It's okay to have silence. And give them that processing time because they don't process as quickly. So they need to have time to sit, think about it, and then come back with the answer. And I even say that there was a survey sent out probably a year ago in Queensland looking around neurodiversity and what needs to happen in the workplace. Look at our interview questions. When we do an interview, the question is huge, isn't it? It's not just what to do in this situation. It's like a 3-4 paragraph. Somebody with neurodiversity will struggle with that. You've got to give them time to process it, time to highlight what the question is, time for them to come back and ask again. Dopamine. Do we all know about dopamine? Yep. So dopamine absolutely is there in neurodiversity. It's lacking. So lots of people are seeking that dopamine hit. So when we see lots of children, they become adolescents and they get into that risk-taking behaviour, they get into substances, it gives them a dopamine hit. So our aim would be primarily to impact when they're young. So they don't start using substances. They don't start having lots of, dangerous sexual encounters. They don't start pushing the boundaries and putting themselves at risk. And an ADHD brain gets bored. Yeah? So it needs to have something to stimulate it. So if we look at dopamine, does anybody have any ideas what could be a healthy dopamine hit? I need you again, Sarah. Absolutely. There's so much research around the art of physical activity with the neurodiversity brain. Anything else? What gives us a dopamine hit? What's that, sorry? iPads, yeah. I'm the worst. I get home from a shift and I look at Candy Crush and it wants me to play. It's bright, it's sparkling, it's saying, this is good. And my brain goes, wow, look at this. Bright lights. Yep. And they've become the norm, haven't they? Yeah, when I was young, we didn't have any of that. You had to create your own fun, and lots of that was just about playing or getting outside or doing things. So as we've progressed, what we've done is we've actually created an environment that's really difficult for a neurodiverse brain to manage. So now if we look at ASD, because neurodiversity, as shown in that first slide, it's overlapping. Everything overlaps. And then if we were looking when we diagnose, it's really difficult. You've got to pull it apart. And again, this is emergency. That's not your role to pull it apart, but just have some understanding how it overlaps. So it's repetitive behaviour with ASD, language, restricted interests. It's on that continuum of severity from mild to, quite severe. We used to say it was on that spectrum. Language changes all the time in neurodiversity world. So it's hard to keep up with what the language currently is. And it's a different way of learning, thinking, perceiving, sensing, moving and empathising with people. especially ASD. So I like this slide because it describes a different way of thinking. So it's creative. They think outside the box. They're fact-oriented. They need to know how things work. How does this work? You know, and kids do that generally. Why? How does that happen? Why does it happen? Drives us mad, doesn't it, as parents, when the kids are constantly asking, what's that? How's that work? But that's how we learn, even if we're not neurodiverse. We need to know how things work. And they're more visual and kinesthetic learners rather than social and verbal learner. Relating, they're honest, direct. They are difficult to communicate, especially on the outer spectrum. And they have a different sensory system for both external with their sounds, that touch, smell, and their emotional senses. And they perceive noises, you know, in detail. They perceive it differently to the neurotypical brain. Moving for some, not all, there are particular mannerisms. Toe walking, flapping. You know, my grandson's 2.5 and he calls me Grammy. He says, Grammy, Nixon walks on his toes. Nixon's not allowed to walk on his toes. So already in the back of my mind, I'm going, okay, something just to, just monitor. There's nothing bad about it. We just need to know how to manage it if it becomes an issue. And empathizing. They're overwhelmed by other people's emotions, okay? And they're unsure how to cope and to convey their strong emotions that they have. So hence when we get to sensory, you know, we often use tools to help them. So I put this up because I like the old attitude and I like the new attitude. So if you just want to take a couple of minutes rather than listening to my voice, but look at the old attitude we used to have. I'm weird and defective. Well, no, I'm neurodiverse with many personalities, strengths and abilities. You know, we need to start seeing it in a different light. We need to start looking at a strength-based approach to our children and adults with neurodiversity. I'll give you just a couple more minutes just to read those. Okay. So if we look at the symptoms, deficits in their social communication, and this, as I said at the start, is a big key to what I want you guys to take away. So they have trouble developing, maintaining and understanding relationships. Okay, they engage in imaginative play to challenge and adjusting to varying social situations. That social emotional challenges, they range from a lack of back and forth conversation to reduced sharing of interests. And that deficit in non-verbal. And again, we're looking at people on the lower end of the spectrum that are non-verbal. Okay, so again, that restrictive repetitive behaviour, it's just the same as just what I said, but it's just a good slide to look at. So that insistence on sameness, inflexibility. You know, you can't change somebody with ASD. If you put something on their plate and they're not used to that texture on their plate and that food on their plate, you will have an outburst. So it's understanding around that for the person. Their patterns, their greeting, their rituals. They have fixated interests. I mean, we all do. But with neurodiversity, it's more intense. And they have that repetitive motor movement, as I said, and that's on the, you know, the higher end with the flapping and the toe walking. And the sensory processing difficulties. So textures with an ASD person. When you're looking at symptoms, lots of people with ASD will talk about they don't like certain textures. Yep, so there's certain clothes they like, there's certain clothes they don't like. Some won't like to walk in the sand, and some that's okay. So it's understanding when you're looking at the symptoms as to what that is for that person. Yeah, and it's important to understand that. Because if they come in and you're putting them in an environment that's going to tip them over, you know, just because that's what, you know, we have to do, you have to sit on that blue chair, and they go, I can't sit on blue chairs, you're going to have an outburst. So it's being understanding and asking, you know, asking the person or the parents, you know, is there a sensory difficulty? You'll pick it up if somebody has neurodiversity, and you can ask those questions. It's not rude to ask. This is a quite busy slide, but if you just look at adult ASD for a change from the children. So it's similar to children, yep, but it's more set. So if somebody hasn't been diagnosed and this has been progressing for a long period of time and they haven't learnt strategies, it's really difficult. You know, if we look in hindsight, God, when I was a child, ADHD was that, naughty, was the naughty boy in the room, too much preservatives in the food, too much red cordial, you know, and that was the stigma. So lots of parents didn't get their children diagnosed because of that stigma that came with it. And the same with ASD. My nephew is 18, very high functioning, but when he was 1.5, he was self-stimming on the television. It was a really difficult conversation to have with my brother. I think there may be a bit of neurodiversity here. And they've done well, they've linked him, he's developed to have eye contact. He will now hug and give a hug back. In the early days, you wouldn't get that. He wouldn't poo in the toilet till he was 5. He'd asked to put his nappy on to do a poo. So it's about understanding that and working with those challenges. So the tips and reminders. Autism is a spectrum. If you think of a rainbow, you know, it's a linear of symptoms. On its own, it's a difference, but it's not a disability. And as I said, most of us who work in health actually have elements of neurodiversity because that's why we do well in the job that we do. Most autistic people refer autism as the first language or the term neurodiverse. And as I said, it changes all the time. We used to call it school refusal. Now they call it school can't. So lots of kids with ASD can't go to school. It's that whole anxiety that comes with it. It's that whole stigma. The teacher keeps asking them they have to do, you know, learning in a certain way, and they can't. You know, so they feel different from everybody else. So it creates that anxiety and that ability that they just don't want to go. And they're different. You know, they're not defective. They deserve respect, admiration for how they cope in a world, you know. So these are my 10 points, which I do drum on a lot when I work in health. We can't do a huge paragraph to a person with neurodiversity. You can't give them 3 sentences and then move on to something else without checking context. Because most of them will just agree with you, because that's a learnt response. They'll just say yes. So you ask one question, you check context. Do you understand what that means? Do you think you can do that before you move on to the next question? So it's breaking it down. And you have to give them time to process. They will process, they just need that little bit more time to do so. And as I said before, they'll answer those stock standard questions that you ask just with what they've learnt. Yeah? They'll just say yes. When I say to my staff in mental health, when they're doing this whole dialogue on a phone with somebody with neurodiversity and they're going blah, 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 and he's still suicidal, of course they're going to just say no, because they're going, what the hell? They've heard the first bit, then it's la, 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 and then the last bit. You know, you've got to slow your questions down. Ask them one question at a time, and again, always check context. And they find organising things hard. But doesn't mean they can't learn. They learn very quickly how to organise if you give them the help that's required. And I suppose we see that, and I keep saying, we see that other end. You know, we see the other end that hasn't got that support or don't have people that understand. So limit their choices. Don't give them 10 choices to choose from, because they're not going to be able to do it. Yeah? Be clear and concise. Avoid verbal overload. You can tell when somebody has neurodiversity, I always say, I can tell you're full. You can just see it in their face. They are full up to pussy's bow, as I call it. They cannot take any more information on. You see it in their eyes. And you're able to say, I can tell you've had too much information. Let's just sit for a while. Because they're not going to take anything else in at that point. And they need positive feedback to know they're on the right track. So communication in emergency settings requires patience, flexibility and clarity, which is really difficult for us because we are on the go. It's quick, get out there. We need to have a resolution to this and move on. We need to, as I said before, speak calmly, no sudden changes in tone. Because if you suddenly become more dramatic in your voice, they'll pick that up. Use clear, direct language and simple sentences and avoid sarcasm. They just don't get it. What we think's funny, they're not going to grasp. So there's alternatives. So visual aids. Again, on the lower end, I have visual aids up here, which most departments should have. It's for kids that are non-verbal. So show them a card. How are you feeling? Let them choose the card if they can't talk to you. You know, there's stuff on physical symptoms, so they can choose what they can tell you what's wrong with them. Not dear at all to have in your department. If they're purely non-verbal, use sign language. And you don't have to be proficient in sign language. I'm saying you can point to, you know, are you hungry? Are you tired? You know, we just need to learn how to communicate. If we're seeing what we're saying is not getting through, then we need to change what we're doing. You know, it's not about us, it's about the patient. And text-based communication is great nowadays with all the technology we've got. So you can use text-based communication with them. Again, look how busy this slide is. So again, as I keep saying, it's not for you guys to diagnose, but when we're diagnosing, it's difficult because you've got all of this to consider. And again, I keep saying it's giftedness. It's a superpower with neurodiversity. You just need to learn how to harness it. Again, just some more stats. So if we look again at that strategies for parents, with patients, sorry, I'll come to parents in a minute. Again, it's that, as I said before, again with ASD, with ADHD, it's the same. Just treat it the same. There's no set thing, your ADHD, I'll communicate this way. Your ASD will communicate this way. Treat it the same. Simple, check context. And give them breaks. If they're overloaded, give them a break. So sensory tools, which is why I asked you guys to come up and choose something. I have my own sensory tools that I carry at work all the time, and they differ. And we know when COVID hit, we couldn't have these things in our department. But lots of these things are now throwaway. You don't have to clean them. And most people with neurodiversity will know their sensory tools. Most people, if you ask, will tell you what works for them. It reduces anxiety, improves focus, and it gives them comfort. And sensory tools aren't just for neurodiversity. We use it in psychiatry all the time. I'll come to that in a bit. So our aim is when we're treating people is not our aim to make people feel safe in our department, to make them feel comfort. You know, what's happening for you? What can I do to help? I think sometimes we just see this as a problematic area and we just don't want to deal with it. And that all that is going to do is dysregulate the patient more. So you can have more of an outburst than what you had in the first place. So sensory box, very quickly. Your tactile, so you have your fidget tools, textured fabric, and I said most people with neurodiversity will tell you what works, and most will have it in their plan. And if they don't, they're willing to try different things. Like often, even if you're working with a young kid that doesn't have neurodiversity, I often give a fidget tool or something because it takes their mind off. You're asking them really difficult questions. They don't want to answer those questions, but if they're concentrating on something else, you might get more of a conversation from them. Auditory, I think all EDs should have noise cancellation headphones because it's overstimulated. It's overstimulating for me at times. You know, if we have those, easy enough to, clean, but give them that option. Visual, as I said, those communication cards or those liquid motion toys are really good. Weighted blankets, it's something we can't have in ED because it's a prescribed. Okay, for a weighted blanket, it goes on your body weight, and we need to be aware of that. Resistant bands or wobble cushions are really, really good. Oral, calming, scented items. Scented items, you need to be really mindful because lots of scents can also re-trigger trauma. So it's not something I'd say you pull out as your first card because it will re-trigger a traumatic event if that scent gives them that sense of what happened in their past. So ask before you give that. Unscented wipes for cleaning their hands if smells are overwhelming. Hard candy, it's hard in ED to give hard candy, but I must say when I had an operation went awfully wrong last year and I ended up in hospital for 8 days, I couldn't eat and I was having potassium infusions. The old lady next door gave me Werther's. It was the best thing out. Like it just took my mind off while I was sucking on a bit of hard candy to that burning sensation that was going through my veins. Sleep mask, breathing cards and guided exercises are really good. And most of them will have small comfort items. So research. So we know about sensory modulation. It's not new. Russell Barclay, who's a bit of a guru in the States around neurodiversity. So he is really drumming on about early identification, and we can then reduce those diagnoses of ODD and conduct disorder. And some research is pointing to early treatment around medication may change that neuroplasticity of the brain. It's research I want to look more into. I often used to have parents in the clinic I worked in would say, oh, we'd just give them a, medication free on the weekends. Our response is why? Because we're trying to teach that brain how to cope. So why would you take something away from somebody that's giving them the ability to manage? So if we look at the ancient roots of sensory, as I said, it goes way back. So we look at the 18 BC, rocking cradles, swaddling. When we swaddle a child, is similar to a weighted blanket. Worry stones for relaxation. Rosary beads that the Catholics use. There used to be African worry dolls that people would tell their worry to and put under their pillow, and the worry was meant to go away. Music, incense, to balance those emotions. Hydrotherapy. Who here, like when people give Botox, you get offered a ball to squeeze, yeah? So that's sensory. When I have cortisone injections, because I've had a tendon transfer too, but the nurse will tap me on my opposite shoulder, because that takes the emphasis off to that pain that's going into that small thumb joint that I feel like it's about to explode. Because if she wasn't doing that, I'd be screaming. That's just a bit more about the ancient stuff. I just am aware of time, so I'm just trying to get through it. So now I come to trauma, and this is where it gets tricky. To add trauma into this. So neurodiversity is hard enough with all those slides. Add trauma. And what you're going to see is a really difficult ability to try and pull apart what is what. And it takes a skilled clinician to do that. And again, you cannot do that in 1 hour. Anybody that says they can diagnose trauma and neurodiversity in an hour, I'd like to say how. So the confusion. Intrusive thoughts, memories of other reminders of trauma can make a child feel, confused, nervous, agitated, and it can mimic that aggression or impulsivity of ADHD. So what are we really looking at? We need to understand that. The developing brain can be programmed to look out, so they become hypervigilant, which again can mimic lots of that neurodiversity symptoms. And what may appear as inattention and daydreaming is actually symptoms of disassociation. So again, you need to be mindful of what's happening in front of you. So brain development studies for ADHD and child maltreatment show significant similarities. Children with ADHD and complex trauma, they need that sense of control with limited choices. Consistency, predictability and routine, both at home, at school, wherever they are. It helps to develop that lasting, safe, predictable relationships and those key support people, and learn to build on their strengths and resiliency. Actually, I had some case studies, but I was wondering if you guys, in thinking, want to throw up a case study for us to pull apart, or do you want me to discuss some quick case studies, because I'm aware of time. Do you want me to do some? Yeah. So this is a 22-year-old male who I know well. He's got a trauma background. He often disassociates. And when he's unwell, he goes by a different last name. And he has periods of catatonia. Triggers are new people in the house, or the parents are returning. The parents have now actually dumped him in a house on his own. Parents have sort of given up on him. When he drops, which he does drop in triage all the time, or if it's too highly emotive, he'll drop. He can hear everything that's said around him. He will blink. So 1 for yes, 2 for no, or 3, I don't know. I use simple, direct statements like, follow my feet. Luke, I want you to follow my feet. I want you to come with me. I pulled him off a bridge one time. He had one leg over. And when I got him in the ambulance, he said, I wouldn't have hurt myself because I have a rope in my pants. So what are you doing with a rope in your pants? Yeah. And when we interact, we can increase that trauma response for him. He does, when he snaps out of it, he'll go back to his own name. He likes jazz, so I often put a bit of jazz on the ambulance. I'll just sit with him. When he can talk to me and go back to his normal name, I know things are okay. And then we can let him go home. He doesn't need to come into ED. He just needs a little bit of time to re-regulate. This is another one. It was a 15-year-old male, so QS were called by the mother. So the parents were saying they were wanting to relinquish care. They said that he was being aggressive with mum. We'd had several times when he'd been brought into ED with the same. When we arrived, he met us. He came out. He was well-mannered, beautiful little boy. He said, "Thank you for coming. I'm okay now, but mum's not okay." So on arrival, when I walked into the house, the stepfather's response was to me, "Take him. We don't want him. We've had enough." So I had to be really firm but caring with the stepdad to say, "We need to be mindful what you're saying. You're saying this in front of the children." Yep. So I made the stepfather come away and talk to me. The patient was told by his mother he'd be returning to live with his grandmother in 1 week. So this little boy, his background was he grew up in the Philippines. He lived with his mother and biological father up until the age of 1. He's never seen biological dad since. At the age of 1, he was put into grandparents' care who were both doctors. He had neurodiversity. They chose not to medicate, but they homeschooled him instead. Granddad then died, and grandmother had a stroke. So he was upheavaled into moving from the Philippines to Australia when he was 13. This is a child that has limited English, has seen his mother once from the age of 1 to 13. Where have we got to? So he was very gifted. He was in the excellence class. He was loving being in Australia. The interaction I noted with the mother, he kept trying to get mum to give him some eye contact and some attention. Mum was a nurse. She worked publicly and privately, and she chose to work 21 days straight so she didn't need to deal with him. So the outburst that day was because he'd formed a good relationship with his case manager in mental health. She'd come home from a night shift. He said, "Are we still going to be able to see Stephanie?" And she said, "Nope, I'm too tired." So he became quite heightened, and he was grabbing her, crying, asking why he couldn't go and see Stephanie. So with that case, my QAS officer went in and spoke to the boy. I spent a lot of time with the parents, talking to them about what relinquishing care meant and the process that that would involve. We spoke to them a lot about the background and how that could have impacted on him. He also had a step-sib that he was watching getting all this attention, and he was getting nothing. So if we look at, when we look at a diagnostic point of view, this is a kid that had reactive attachment disorder. Yeah. And then he had adjustment disorder because he had to come over to Australia. English was his second language. He had to come live with a mother, stepfather whom he'd never met, and a sibling who he perceived was getting all the attention. He was set tasks, and he was trying. He would say, "I'm trying to do my best. I'm trying to clean my room the way they want it." When he was living in the Philippines, he had maids, he had cooks, and so he was trying, but they didn't perceive it was good enough to their standards. With him, there was a light bulb moment that we were able to get with the parents, where I think when we talked about maybe, what's happened to him as a child and all these things that are happening now could be interacting, they agreed for him to stay for that 1 week before they were sending him back. I must say my QAS officer came out after speaking to him, and she was in tears. So when we look at, has everybody heard of we call it the 5 Ps. I've just put the 4 Ps up there. Have you heard of? So in mental health, we call the 5 Ps. So presenting problems, predisposing, which is your biological, precipitating, what's causing it to happen right now, perpetuating, what's keeping it going, and what are the protective factors. Because unless we address all these, we're band-aiding. We're sending the person out and they'll reoccur because we're not addressing what the issues are. I'll skip through these because I know I've only got 10 minutes. Skip through that one. So I was going to do a reflection, but I know we've only got 10 minutes. But what I maybe thought, what I might want to do, because even in mental health, as I said, sensory is not just for neurodiverse. So often if somebody's self-harming, we use sensory. So often I'll have kids that are slashing up, and instead we'll get them to either use the use of a lacquer band, something that inflicts pain, has to be a tight lacquer band that will really hurt, but it's not going to cut the skin. So when people self-harm, it's a distraction. Yep. Physical pain will take away that emotional pain, and physical pain to them is better than that emotional pain. Often if I can have a volunteer, who wants to come up? Anybody? Rob, you'll do. TikTok. We can put it on there. So often I also talk to people about holding on to ice. So if I'm on the road to a patient, I know them well, and they're saying I'm cutting, I'll say, I want you to go to the freezer. I want you to grab some ice. So Rob, if you grab a handful of ice, I want you to hold it tight in your hand. Hold it for a length of time. So eventually that will burn, but it's not going to leave a scar. So eventually when we're looking at, you can have a sour lolly too. Eventually when we're looking at trying to change the person from their behaviour, you're not going to say stop self-harming and they'll just stop. You've got to try and give them strategies that help them put in place what they're trying to achieve. So things like, is it burning? Okay, you can put it back. The other thing, Rob, while you're here, do we have a knife? Oh, yep, here, Rob. So the other thing we suggest, we should put this on TikTok for Rob, is take a big suck of a lemon. I want a big, big suck on that lemon. In actual fact, I maybe do. Is that nice and sour? So often a sour sensation will take away from what the person's feeling. So there's tools we can use. Yeah, I do have sour lollies. Yeah. The use of different teas in AD. We have tea and coffee. Why don't we offer chamomile tea if somebody's distressed? Yeah. Or we have scents. And again, be mindful of the scents. If somebody's got that trauma history, we don't want to re-trigger. I'll give you something now, which anybody else can come up, because I know we're on the countdown and you've got the closing party. Okay. So I'm only doing this for you guys because we do not do this to our patients. We'd be very poo-pooed and would be struck off. So this is some straight vodka. I thought I'd give you guys a warm-up to your closing party. Take a big skull.
Yep.
Yeah. So, yeah. So sensory does the trick. It will take your mind off things. Does anybody else want to come up and hold some ice, suck a lemon, or have some straight vodka? No one? Oh, we can stay up here for a bit longer, Rob. But sour lollies, easy to get. You know, kids love sour lollies and so do adults. I hate them because it's that, but it does take your mind off what's currently, you know, problematic. Do you agree, Rob?
Absolutely.
Yep, there we go. Do you want another shot of vodka? Might take the pain of the tattoo away. You can sit down now. So at Gold Coast, what we're trying to do is we try and look at all problems and how we can manage it instead of having all those silos, how we can manage it together. So we are building a new hospital in Curammeng because we're inundated. That's going to have a designated sensory room for neurodiversity there. We're trying to improve our communication awareness. So more of these talks we do with our staff. You know, that simple thing, check context. I know you guys are busy. And that's what we say to our ED friends. I know you're busy. But the more you don't treat the person with what they need, it's going to keep dysregulating on you. And the key points for you guys, communication is the key. So you need to understand it and you need to communicate effectively. You guys, as I keep saying, you don't need to diagnose. You don't need to know how we diagnose. It's a very complex matter, but it's communication. And that checking context. Check context before you move on to the next question for the person. And low stimulus. If we can get them out of there, I often bring kids in and we have the blue chairs, we call them. It's the worst place we can put somebody with neurodiversity. They're sitting beside somebody who's intoxicated on meth and they're aggressive, and especially if they've got a trauma history. We're re-traumatising the trauma patient. So we need to be mindful where we place them. Often peds will say, oh, but they're aggressive towards their parents. It's not in the context they're an aggressive kid. They're aggressive because they're acting out because of what's happened to them. They're not going to go around with a stick and bang every other child on the head. Like, that's not going to happen. And our awesome team. So have I done time? Have I done well?
That's perfect.
I always digress, which is my big thing. So any questions that anybody wants to ask, I'm happy to answer.
Does anyone have any questions for Kim before we wrap up?
That would be a question for Sarah. In the ED, do you guys have different like lanyards for the patients to wear to identify that they're neurodiverse or need some?
It's not a green lanyard. I can't remember what colour it is, but particularly in the paediatric area, there are things to identify neurodiverse patients.
Yep.
Yeah.
So it's a skill we keep working on, and sometimes I feel like I bang my head against a brick wall. You know, I've been working in mental health for 35, coming on 36 years, and I feel like there's so much overshadowing, there's so much bias that sits with mental health and with neurodiversity. But slowly I think I do see progression, and I do see that people are taking it on board, which is great. So as long as we keep taking steps forward and no steps back, then that makes me happy. Any other questions?
Awesome. Thank you
Okay.
so much, Kim. This is such an emerging space. Thank you for bringing practical strategies to us. Thank you for bringing toys and vodka. My son did say to me before I left for Bali, he said, can you bring me back a Bali toy? So thanks for getting me out of hot water. Not with the vodka, no. Thank you again. Okay, so this brings us to the end of the Bali EMS conference. So just a couple of last things from me before we go on our way and before we go out to see each other at the closing party tonight. I'm really proud to announce that EMS Conferences, along with our friends at Everest Wealth, donate a portion of sales to a charity of choice every year, and I'm proud to announce that we've reached our 2025 goal of $10,000 going to Orange Sky, which is a charity for laundering homeless people's clothes and laundry. So yeah, that's really special. I just do have a couple of thank yous. So firstly, can we just thank Coco and his amazing AV team for keeping the sessions running smoothly throughout this week. Thank you very much. Terima kasih banyak. Thank you to our friends Delphine, to Max and to Choc for all the logistical support, our friends from Locum Life, I should say, for all of the logistical support throughout the conference. Really, really very much appreciated. Can we give our friends at Locum Life a round of applause? We owe a huge round of applause and thank yous to Epi and the amazing staff and team at the Trans Resort in Seminyak, who without them this would not be possible, kept us fed, watered and happy and healthy. So thank you so much. Thank you to all of our amazing facilitators who have presented throughout the week and provided such valuable insights. It's just been truly outstanding. I go home with so many nuggets of knowledge. So thank you so much to our presenters throughout the week. And finally, thank you to everybody who's come. Thank you for everybody who travelled from around the globe to be here. This conference has been truly wonderful. We've had great dialogue, great interaction. So a big round of applause for yourself. Thank you so much for being here with us. Now, it is the closing party tonight, so 7:30 at Dharmaria in Seminyak. I posted a little map in the WhatsApp chat and how to get there. If you are walking, then maybe just get yourselves together a walking party. It's about a 20-minute walk. Food, drinks, pizza, bring your lanyard for ease of access. Before you go, can I just ask that we complete the feedback form? Scan the QR code on your desk and complete the feedback form, please. We are trying to improve these every single time. If you think something could be done better, if you didn't like something, or if you just want to give us a warm and fuzzy, we'll take those too. But we're always interested in hearing from you, so please do that. Otherwise, our conferences, the next one is in Japan in January, so have a look on the EMS website. Ideally locations all around the globe. We hope to see you at future EMS Conferences Australia. Otherwise, we'll see you tonight at Dharmaria. Thank you so much and goodbye.